Tamsulosin, the alpha blocker, is supposed to have this side effect of orthostatic hypertension. So the conclusion was combination therapy proves to be efficient and safe for early stone expulsion. Tamsulosin monotherapy can be considered as an alternative treatment in those who are not suitable for steroid therapy. So wherever it's feasible, the combination can be given. Another study where the stone size of 4 to 10 millimeters were studied in two groups. First group was given combination therapy and second group was given only tamsulosin. And the expulsion rate was better in the combination therapy group, 76% versus 52%. And the median time of expulsion was also less for the combination therapy patients. So by adding Deflazacort becomes very effective without significant side effects as were seen in this study. Another study where combination therapy versus tamsulosin monotherapy was given. So in this another study where the patients were taken from the who already underwent ESWL. So the patients who had undergone ESWL shockwave lithotripsy, in those patients also the combination therapy and the monotherapy was studied, and it was found that the combination therapy were having certain advantages like number of ESW sessions, stone expulsion rates, median time to expulsion, and number of analgesic used were all better in this group. So the summary of the clinical trial was, it is superior against plain tamsulosin, means the combination, and superior against tamsulosin plus low dose Deflazacort when it was used in lesser dosage, like 18 milligrams a day. So with 30 milligram and 0.4 milligram of tamsulosin and 30 milligram of Deflazacort, it has got all the advantages shown in all the studies. So it is indicated for the treatment of distal ureteric stones less than 10 millimeters and for stone fragments after ESWL or after usually RIRS. Ureteroscopy, when we do from below, usually we remove all the stones, but after RIRS, when we are doing it inside the kidney, multiple stones are left behind, and those stones slowly and slowly they come down through the ureter. That time this medication can help with that. Maximum duration of giving therapy. Usually it's very important because most of the time what we do, we are giving this therapy for a longer time, but actually it's certain times we can give it. If primary patient of having stone in the ureter is coming directly to you, so in those patients we give for 3 to 4 weeks, not more than that, because if the stone has to come out during this period, it will come out. Otherwise, if stone is not coming out, there may be some anatomical problem, or the size of the stone itself, or the shape of the stone itself, or the surface of the stone itself that is not going to be. So if we are waiting for more than 3 to 4 weeks, ultimately what happens, if it is completely obstructing the ureter, then in that case what happens? Not only hydronephrosis, the loss of nephron starts. So the damage to the kidney starts after. Yeah. So we wait in almost all the patients, unless until the patient has developed fever because of the infection, or the patient is a diabetic, or if the patient's need of analgesics are too high. In those cases, we advise directly to go for surgical intervention rather than waiting and giving this.
Case of diabetes, is contraindicated.
It's contraindicated in that case. So the dosage, as I told, 0.4 milligram of tamsulosin and 30 milligram of Deflazacort. The good thing is in renal impairment, no dose adjustment is required, and hepatic impairment also, if it is unless until it's very severe impairment, no dose adjustment is needed.
Is also a BPH stone.
Pardon?
MPH, mineral prostatic calcium.
Yeah, but we don't use tamsulosin use, but we don't use daplasoport usually. Basically, it's not giving any additional advantages. So there we have to be careful when we are using this combination, as tamsulosin causes hypotension, so orthostatic hypotension may develop. In calcium prostate we don't use. In patients who are going to have some cataract surgeries, there also we have to think before advising this. It causes some endocrine function alteration in cardiovascular function, and immunosuppression because of the daplasoport. Contraindication is severe hepatic impairment. It is not recommended in pediatric population. Basically, it is not studied in that population. And if the patient is hypersensitive to either tamsulosin or daplasoport, we cannot use it. Drug-drug interaction, tamsulosin plasma concentration increases when concomitantly administered with ketoconazole, paroxetine. Hence, we should be cautious about when we are giving these medications. Daplasoport also have decreased by about the concentrated dose should be decreased about threefold when given with clarithromycin, fluconazole, DTSM, verapamil. Concomitant use of daplasoport with strong moderate these inducers like efavirenz and carbazepamine, phenytoin should be contraindicated. Should not be given. Adverse effects because of the tamsulosin is orthostatic hypotension. Retrograde ejaculation said that with tamsulosin it's quite less. Mainly we see it with silodosin, not much with tamsulosin. Nasal congestion can happen, rhinitis, diarrhea, alteration in endocrine function, immunosuppression, increased chances of infection, alteration in cardiovascular and renal function can be seen. So these are the side effects of this. And what is the place of this fixed dose combination of these two medications in medical expulsion therapy? 0.4 milligram of tamsulosin and 30 milligram of daplasoport is indicated for the medical expulsion therapy of distal ureteric stones less than 1 centimeter, or the stone fragments which are made after ESWL or retrograde intrarenal surgery. Thank you.